Thank you, Roberta. We'll now move on to the second topic of today's broadcast. Another area that can challenge organizations is that qualified staff receive and record verbal orders in a satisfactory fashion. Waverly Health Center in Waverly, Iowa has been making efforts to improve its handling of verbal orders and, in fact, eliminate them where possible. Waverly is a 25-bed critical access hospital with approximately 420 employees, including physicians and mid-level providers. They have recently been redesignated as a Plaintree patient-centered care hospital, one of only 15 such organizations in the country.
Here at Waverly Health Center, we try to minimize the amount of verbal orders as much as possible. And as we're implementing the electronic health record, we are looking at ways to reach a goal of eliminating that. Probably in the real world, we'll never be able to completely eliminate them, but everything that we look at is a goal of providing the opportunity for the providers to directly document the orders so that we do not need to have that extra step of verbal orders and read back so that we can promote patient safety. With verbal orders having been one of the national patient safety goals, we talk about patient safety at all of our leadership meetings. We talk about patient safety with staff as we're rounding and interacting with them, always asking them ways that we can improve with patient safety. And verbal orders has been a priority for us since the National Patient Safety Goal was implemented.
Our medical executive staff helps communicate changes and concerns about verbal orders and nursing concerns through our bi-monthly meetings. And then we also have a monthly newsletter that is sent out to every physician. We fully understand that some physicians read our letter, some of them don't. So we try to approach the communication barrier in 3 or 4 different methods so that hopefully everyone's exposed to it.
I think hearing other success stories, I think is good. I think hearing the benefits of what's going to be coming, how it's going to improve hopefully patient care. I think hearing those things, makes us a lot more happy to try to help with implementation of change.
On the med-surg floor, if you have a verbal order, basically you're writing it down on the provider's order sheet and reading it back to the provider or whoever dictated it to you. And then at that point, the nurse documents it by adding an RB followed by her initials after the signature line.
Good afternoon, medical desk. This is Kathleen. How can I help you?
Hi, Kathleen. This is Dr. Adams. I have a couple orders on Terry Smith. His date of birth is 9/4/32.
Okay, let me just grab his chart. It's right here. Okay, and what would you like us to do for him?
I would like him to have Lasix 40 milligrams IV now, and then repeat his chest x-ray and electrolytes in the morning.
Can I put you on hold for just a moment? Okay, just a second. Hi.
Okay, I'm going to read this back to you. Lasix 40 milligrams IV now, and repeat the chest x-ray and electrolytes in the morning. And this is, yeah, okay. All right.
Yep, that is correct. Thank you.
You're welcome. Bye-bye.
Some of the challenges we had with the verbal orders with the providers and the nurses started out with the fact that nurses weren't always comfortable at first telling the provider, I need to read these back to you. It helped for them to read one order at a time back. So if the provider was making a telephone order and listing off all of the admission orders, if they read every admission order back, read it back immediately, that was helpful.
One way that we've approached this is by increasing the use of standing orders. We found that a lot of our verbal orders on the floor were related to routine things that were missed with the base orders that the physician wrote. So we have a very extensive standing order set that's been approved by the physicians in committee and through the medical executive staff and also through the pharmacy. This has dramatically eliminated the need for nurse callbacks after an admission.
Recently, we've had issues with providers making statements in the patient rooms, like, I'm going to give you this medication today. The nurses expect that that's the conversation between the patient and the provider, or even to them. Their expectation is that the provider goes out and enters the order in CPOE or writes the order. Some of the providers weren't always doing that. So the nurses ended up, because they have open communication with the providers, saying, you know, we didn't know if that was a verbal order or if you were just talking to us and the patient. We expected you were going to write it down. So if you're going to make statements in the room, would you please tell us if that's a verbal order, because we'll need to write it down and read it back to you if it's the order. The data we collect to check on whether we're on track with our verbal orders is through a chart audit. And on the medical surgical floor, we review all of the inpatient and outpatient charts for a month, for 1 month during the quarter. And we're looking at the number of verbal or telephone orders that there are that month, the number that do not have the readback documented, and then which nurse isn't documenting the readback. We're looking for a trend to see if there's a certain nurse that's missing it or if it's just random.
But at Waverly, chart audits are not adequate to ensure the staff is doing readbacks. Managers also make random checks.
We discuss the data collection information at the staff meetings. We let everyone know where we are, what percentages we have for our data collection, and then we discuss if there are any issues, how are we going to resolve those.
Also at Waverly, because of the different circumstances of the emergency department, nurses there require that providers not even give verbal orders.
We have focused a lot on the computer physician order entry and how that affects the flow, patient flow, and the flow from the orders to the nurses, and how those orders are verified and then carried out. We have come to the basic understanding between the providers and the nurses that the providers will enter all the orders first, and then the nurses will carry them out. So we have basically eliminated the need for verbal orders, except in the emergent situations, as in traumas or code situations.
You know, one of the big challenges would be, you know, at times, you know, for me particularly, and I've heard some of this from my colleagues, sometimes a medication that we would use commonly in the ER, it might be listed a little bit differently in the computer system. So, you know, that's probably one of the things that has been the most challenging. But I think with a team approach from pharmacy, you know, our colleagues, nurses, administration, I think we continue to improve things and work around that. And I do feel that every week, you know, things are improving and getting better.
We built these orders kind of on the basis of looking at other facilities and how they had their orders set up, and found out that they weren't really user-friendly. So there have been many revisions and re-additions to those orders as we've gone through the process. And the other issue we have come across is we encourage our nurses to do their charting and their assessments in the patient rooms. So if the provider is in the room at the same time, he needs to go back out to the nurse's station to enter the orders, which causes a delay. So we have instigated a laptop that the doctors are using. They can take into the room with them and put the orders in as they're talking to the patient, and that cuts down on the delay of those orders.
Communication is such a complex area that's very difficult because of the human factor that's involved. So one of the efficiencies that we have experienced is reducing the amount of callbacks to providers, so that if they write the order, it's much more clear. Perhaps if we take a verbal order and there's a question about it, it might be caught later on in the processing with the pharmacist, which might require us to call the provider back. That's disruptive to them because they might be taking care of another patient, as well as it delays the implementation of providing that medication or that treatment to the patient because we're waiting for communication with the provider.